Welcome everyone to today's session of our NOW program educational webinars. Today's topic will be brain tumor symptoms. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the NOW team for this continued partnership. The recording of the session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the Q&A feature throughout the session. At the end of the session, your questions in the chat will be used to moderate the Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Rachel to introduce our panelist.
Thanks so much, Sierra. Hi, everybody. Welcome to our first Neuro-Oncology Wellness Education webinar of 2025, a momentous occasion. The Neuro-Oncology Wellness, or the NOW program, is an initiative from the Center for Neuro-Oncology at Dana-Farber Cancer Institute with a mission to educate patients and their caregivers about brain tumors, as well as provide resources to promote overall health and well-being. I am Rachel Garcia Fox, the program administrator for NOW, and thank you for joining us today for this live NOW webinar on brain tumor symptoms and their management. I'm delighted to introduce our panelists, Drs. Lee and Rhee. Dr. Lee is the Director of Clinical Research at the Center for Neuro-Oncology and an Associate Professor of Neurology at Harvard Medical School. Dr. Lee also serves as director of the Mass General Hospital Dana-Farber Cancer Institute Neuro-Oncology Fellowship Program. Dr. Lee is a recipient of the American Academy of Neurology Young Investigator Award and has been involved with translational neuro-oncology research for over a decade. Dr. Rhee is a neuro-oncologist and palliative care physician at the Center for Neuro-Oncology and Department of Supportive Oncology at Dana-Farber, and an instructor of neurology at Harvard Medical School. Dr. Rhee leads a supportive care clinic and research programs addressing the supportive, symptom, and palliative care needs of patients with central nervous system tumors, with the goal of improving their daily lived experience. He is a young member of the Pontifical Academy of Life, a bioethics advisory group for the Vatican. Drs. Lee and Rhee, thank you so much for joining us today.
Thank you for having us.
Thank you.
Before we start, just want to remind our live audience that we want you to be a part of this conversation by submitting your questions via the Q&A feature at the bottom of your Zoom screen. We'll select a number of your questions for our guests to answer in the second half of the program. Let's go ahead and get started. The words brain cancer can evoke frightening thoughts in the minds of many individuals, and it's not uncommon for people to think that they might have a brain tumor in the presence of certain symptoms. Dr. Lee, start us off. How common are brain tumors, and what are their usual presenting symptoms?
So first, let's start off by defining what we mean by a brain tumor. Obviously, this is a tumor that started in the brain, but there are actually many different types. They can range from benign to aggressive or malignant tumors. And tumors that started in the brain are called primary brain tumors, while tumors that came from somewhere else in the body, say the lung or the breast, are called metastatic or secondary brain tumors. So in terms of how common are they, primary brain tumors are actually relatively uncommon, particularly compared to, say, breast cancer or lung cancer. There are only about 20,000 new cases of malignant primary brain tumors that are diagnosed in the United States every year. In terms of metastatic brain tumors, those are much more common. The exact incidence is not known, but it's somewhere between 100,000 to 300,000 per year. And the presenting symptoms often depend on what part of the brain is involved. As you can imagine, different parts of the brain control different functions, so that if you have a tumor located, say, in the speech area, your symptom might be difficulty with speech, for example. If the brain is irritated by the tumor, it can result in a seizure. Brain tumors can also cause increased pressure inside the head, and so some people might have headaches with nausea, vomiting, or confusion.
Thanks so much, Dr. Lee, for that comprehensive answer and that initial definition for us of what is a brain tumor. Let's focus in on headaches, why don't we? Dr. Rhee, do headaches associated with brain tumors have any specific features?
So headaches are a very common symptom of brain tumors. There are ranges in the literature going up to as high as 90% of patients with brain tumors experiencing headache. And I think about headaches in different ways. So though we oftentimes categorize headaches into one category, we should probably be thinking about them in terms of the reason behind the headache, because then we should also think about the treatment of each type of headache differently. So, for example, a common headache is post-surgical pain, where more than a headache per se, it might be related to like sensitivity to the scalp or the area around the surgery. And that I would think about in terms of treatment with modalities that are perhaps treating more of the kind of nerve endings that have been severed or damaged or kind of growing back and causing pain in that area. Another type of headache is the actual tumor related to the headache. So the exact like biology of like why tumors cause headache is still not specifically known, but part of the reason probably is that there's a stretching of the meninges, which has a lot of pain receptors. So that's like the covering of the brain. And so with swelling or edema, there's probably some pressure or pain related to that, among other reasons for it. But in those cases, then I might think about pain medications specifically in terms of alleviating that type of headache. There's also headaches related to increased pressure. So sometimes, based on the type of tumor a patient can have, there may be various reasons for having increased pressure in the space around the brain and spinal cord. And so the treatment, again, for that would be different because if it's increased pressure, then you may want to find ways to decrease the pressure by rerouting the pressure or releasing some of the pressure. And then fourth, I would say are migraines. So like just because somebody has a brain tumor doesn't mean that they might not also have an underlying migrainous condition, right? Or maybe precipitate more migraines than their baseline. And so if it's a migraine, then I would also think about the treatment of that differently because there's more evidence for how we treat migraines in terms of prophylactic medications and also abortive medications in the setting of like a migraine that's acutely happening. And then lastly, I would say there's a bigger bucket of secondary causes. So they could range from like kind of metabolic changes to like medication reasons for headache, including medication overuse reasons. Sometimes actually in migraines, for example, using things like Tylenol or ibuprofen variants too frequently over a longer period of time can actually paradoxically cause more headaches. And so there are different other reasons for that. And so for headaches specifically, again, though we categorize them into kind of one large bucket, we want to think about them in terms of what's the actual cause, so we could also direct the treatment to their cause as appropriate.
Great. Thank you for that overview. Here's a follow-up questions for you. So patients often complain of headache after brain tumor surgery. Can you maybe talk about what type of headache, sort of in the ones that you just spoke of, might be happening there? And then how long are those expected to last?
Yeah. So most commonly after surgery, I would say just common things being common, likely related to the surgery itself. There's also some swelling after surgery, and so it could also be related to the swelling. But I often find that patients are talking about kind of a sensitivity to the area in the scalp or the area where the surgery happened. And so if it's that with the recovery process, one would expect, and we see that that improves over time as time passes. And usually I would say in terms of improving of pain, like there's an improvement that's quicker over a period of days, but that still the pain could last for a period of a few weeks. I think that if they last much longer than that, then we want to think about different reasons for the headaches and again, think about different causes that we may want to treat. But in terms of things that are more like surgical related, then I often think about things that might be more topical or things that are affecting or help with the nerve fibers to treat pain related to those headaches.
Interesting. Thank you. And it sounds like if there's a persistence in the headache, that would be reason for a patient to contact their doctor. Any other red flags that would be an instance where somebody who is experiencing a headache, who does have a brain tumor, should reach out to their medical team?
Yeah, it's also a good question. And um, I think that, just to say out loud that headaches are also things that are scary for patients because oftentimes patients are associating headaches with things like progression or whether something might be happening like inside, right? And that with brain tumors, especially, a lot of times patients were diagnosed with brain tumors without much symptoms, and some of the symptoms might have just been like headache. And so I think that there's also additionally a component of recognizing that this is a distressing symptom because oftentimes there's relations or kind of correlations that we have to like the initial diagnosis or kind of the fears of like what might be happening with the brain tumor itself. And so just also recognizing that it's a challenging symptom for many reasons. I would say, yeah, persistence is one reason that one would talk to your physician or your neuro-oncology team about headaches. I would say another thing is acuity. So if it goes from like kind of not having headache to suddenly having really severe headache, the acuity and also the severity are two things that I often think about in terms of whether something needs to be done immediately. Because if something is more gradual over time, then I think about things differently than whether something might like kind of be sudden. Just because sudden things and very severe things oftentimes are related to perhaps some type of change that may happen or some type of insult that we may want to think about in terms of acting on more quickly. I would say the other thing that's more of a red flag is if there's accompanying other neurological symptoms, so like double vision or like weakness, because those are things where the headache may be also related to potentially something happening with the tumor. Again, that's not always the case. Sometimes double vision may be due to increased pressure, and increased pressure is not like always related to progression. So there might be different reasons for it, but a new neurologic symptom is usually something that I think about in terms of a red flag. And then the literature often talks about positionality, just to talk a little bit about the increased intracranial pressure, so increased pressure around the brain and spinal cord that we often kind of hear in the textbook as like typical of like, if you lie down and the headache is worse, or if you bear down, the headache is worse, that's usually increased pressure. I think that that's like overall a good framework and is a good reason, also kind of a red flag to talk to the team about because we may want to do something to reroute the pressure. But I would say that like oftentimes in our patient population, it doesn't follow such a textbook in practice. I would say symptoms in terms of the increased pressure. And so to me, I often think about like the first three things most of all, like the acuity, intensity, neurologic symptoms, and then the persistence.
Great. Thank you so much. And thank you for summarizing at the end there. I was going to say the same thing. I appreciate you going reviewing the four topics you brought up. Let's shift over to another common symptom that we see. Dr. Lee, a common complaint we see with patients who have brain tumors are seizures. What is a seizure and why are these common in our patients?
Yeah, so a seizure is a temporary episode of abnormal electrical activity in the brain. And seizures are generally short-lived, meaning they only last maybe 30, 60, 90 seconds. They tend to come on very suddenly. And even though there are many different kinds of seizures, for one individual patient, they tend to have the same kind of seizure when they do have a seizure. So meaning they're stereotypical for an individual patient. Seizures can occur in brain tumor patients because the brain tumor disrupts the electrical activity of the brain where it's located. So you can imagine that the brain tumor can trigger a seizure in theory. But not all patients with brain tumors will ultimately have seizures. And the risk of seizure actually depends on the type of brain tumor and a few other risk factors. For example, patients who have lower grade gliomas tend to have higher risk of seizures than, say, higher grade gliomas.
Can we classify seizures a little bit more? How do you go about classifying seizures?
Mhm. So we generally divide seizures into either generalized seizures or focal seizures, and they are just how they sound. A focal seizure is something that starts focally somewhere in the brain, and a generalized seizure is something sort of that spreads throughout the brain. So the most common type of seizures we actually see in brain tumor patients are focal seizures. As you can imagine, because the seizure emanates from the tumor, that's a focal area, right? And we can break down focal seizures even further into either focal aware seizures, those are seizures where people are still aware and they remember the seizure, or focal impaired awareness seizures where the patient is confused from the seizure and then may not remember it well. Um, the semiology or appearance of the seizure can vary, again, depending on where in the brain the tumor is located. So again, another example, if you have a brain tumor that's located in the part of the brain that, say, controls movement of the right leg, and a seizure emanates from that area, then you can imagine that patient would develop what we call a focal motor seizure, which results in jerking of the right leg. On the other hand, uh, generalized seizures are seizures, again, that spread throughout the brain. In theory, patients with brain tumors can also experience generalized seizures, which are associated with loss of consciousness, and sometimes you can have whole body shaking. But often the seizures are actually start focally, and then they can, in theory, spread throughout the brain, and we call that secondary generalization.
Thank you, Dr. Lee. Very interesting. Going back to the focal seizures, for patients that do experience focal seizures, could they be having a seizure even if they don't have any twitching in their body?
Oh, yeah, sure. Absolutely. As I mentioned, the seizure manifestation depends on where in the brain the tumor is located. Again, this is the area where the seizure typically emanates from. So if a seizure is emanating from a part of the brain that doesn't control movement, you're not going to see twitching. So one area, just as an example, that's particularly prone to seizures are the temporal lobes, right? So examples of temporal lobe seizures can include things like sudden feeling of déjà vu, a familiarity or unfamiliarity, a strange metallic taste in the mouth, a strange smell that no one else smells, bizarre behaviors, things like that. Um, so there are many different kinds. Now, clues to suggest that you might be having seizure is generally sudden onset, unexplained event, typically brief. And again, for one individual patient, when they have seizures, they tend to have the same kind of seizure when they do get them.
And let's say a patient is experiencing a focal seizure, what recommendations do you have for that person?
Yeah. First, you want to make sure that you're in a safe place, right? Such that if the seizure secondarily generalized, that you would not injure yourself. Or if you lost consciousness, that you wouldn't injure yourself. You want to notify the people around you that you're having a seizure, so that way, if someone needs to help you, they at least know what is happening. Sometimes the doctor might prescribe you a medication such as lorazepam that you can take to help break the seizure when it's happening and to prevent it from progressing further. And in general, yeah, you should definitely call your doctor to let them know that you've had a seizure, as it might require a change in the anti-seizure medications.
Speaking of anti-seizure medications, how important are they in helping to prevent seizures?
Oh, yeah, they're super important. Seizure medication is very, very important for preventing further seizures. If you are a patient that has already had at least one seizure, the risk of seizure remains elevated, right? So we want to make sure that you don't have further seizures, and the only way we can do that is really with anti-seizure medications.
Now, sometimes patients may experience side effects with these medications. Can you tell us a little bit about the side effect profile, what people might expect if they're going to be on one of these medications?
Yeah, the side effects really depend on what anti-seizure medication you're taking. Some of the potentially common side effects that occur across almost all the anti-seizure medications are things like drowsiness, fatigue, unsteadiness. Some of the seizure medications can cause mood changes, others can cause skin rashes, and it really varies from person to person whether you will experience a side effect from these medications or not.
Thank you, Dr. Lee. One more question for you. Aside from taking medications, any other steps that can help with seizure prevention?
Yeah, so patients with seizures should avoid any factors that might trigger their seizures or lower their seizure threshold. So, for example, we recommend good sleep because we know sleep deprivation is a big trigger. We recommend avoiding stress as much as you possibly can, maintaining a healthy lifestyle, avoiding excessive alcohol use, just things that that come along with healthy living.
Great. Thanks so much, Dr. Lee, for that overview. Dr. Ree, based on what Dr. Lee just said, it sounds like confusion could be a possible seizure kind of appearing, could present as confusion. Can we talk a little bit more about confusion in brain tumor patients? Any other causes for confusion?
Yeah, so confusion is a very broad term in medicine, and because confusion can really happen due to almost anything. Not to be like super broad, but in reality, in brain tumor patients can be a very broad differential, ranging from things like infections to additional insults in the brain, like even things like strokes, but like really anything. Delirium, like metabolic reasons, medications. So actually, the list can be very broad. But I would say just thinking also about common things being common, seizures are among the most common reason for confusion among our patient population. And that usually, as Dr. Lee was mentioning, like when the seizure is like longer, it oftentimes leads to longer kind of confusional state after the seizure. And then also like if a seizure is more generalized, like loss of consciousness, then oftentimes has a little bit longer recovery because then like the whole brain was involved in this like electrical depolarization. I would say the other common reason that we think about is related to swelling. So swelling can be due to many things, can be due to a tumor itself. It can be due to like treatments too, like radiation oftentimes can cause swelling. So swelling itself, because it's pushing on other aspects or areas of the brain, can also be a reason for confusion. And I would say that would be the other more common reason that we think about.
So it sounds like confusion could be how a seizure presents itself, but it also could be something that someone experiences after they have a seizure.
Yeah, that's right.
Great. Thanks so much for explaining that. What do you recommend that families or caregivers do for a patient who is confused or off their baseline, maybe from a cognitive perspective?
Yeah. So if it is a seizure, I often find that to a degree, it depends on the level of comfort also of the family, in the sense that, if it's somebody who has like a focal seizure and this is something that has happened before and it's a semiology or like the kind of characteristics are the same and over time, like the family feels fairly comfortable managing it and the seizure lasts a brief time and they're returning back to their baseline could often be managed at home. As people on the call know, we also have always like somebody that can be paged if there's concerns about what to do in a particular situation. But I often find that if families have like a lot of experience, that they also tend to know how to manage the situation, especially if it's something like that's short lasting and the recovery is happening quickly. Um, if it's gradual too, like the confusion, it's not like a suddenly one person wakes up one morning and is confused. Again, that's like the acuity kind of concern, but it's just kind of been like the subtle, gradual change over time. Then sometimes also it could be managed from home because if you reach out to a neuro-oncology team, it could be that maybe there might be more swelling, and so increasing the steroids might help with the confusion, for example. And so then there are also like things where maybe it's like happening more of a slower pace that could also be managed from home. But I would say in most instances with confusion, though, it is important to be evaluated by a medical practitioner, again, especially if it's like severe and acute or persistence too. And then having also other neurologic kind of manifestations too, similar to headache. Those are all kind of red flags, no matter like whether it's like seizure related or confusion related, because the causes of confusion like headache can be very, very broad. And I would say confusion, even more than headache, is even more broad for the reasons. Because of that, having some type of evaluation, if it's not something that happens repeatedly in the sense of something that we know, like what the reason for the confusion is, evaluation by a medical professional is important.
When in doubt, reach out. It's a good policy. Another complaint in brain tumor patients is a weakness, which is inability or reduced ability to move an arm or a leg. At times, it can make walking more difficult for people. What are some causes of weakness in brain tumor patients, Dr. Ray?
Yeah. So also there are many reasons potentially for weakness, but including things like deconditioning after a hospital visit, or maybe even like in rare cases, something like a stroke. But I think, again, talking about common things being common in our patient population, I would say still oftentimes I'm thinking about seizures or swelling. Because after a seizure, especially if it's near the motor area, then what's happening basically with the seizure is that there's kind of a coordinated electrical activity that's happening in the area. And so afterwards, that electrical activity is like not shooting anymore for a period of time. And so you could have this weakness for a period of time after a seizure. And so because of that, after a seizure, we often find that there's weakness if there's some type of motor seizure, and that kind of slowly improves over time. Also a gradual weakening, oftentimes I think about in terms of swelling, though sometimes it could be faster than gradual, especially in the brain. It's related to whether it's near the movement area of the brain, so the motor area of the brain. And so if there's swelling that's kind of pressing on that area, that could also be a reason for weakness. And that also we could treat with, for example, steroids to try to like decrease the swelling in that area.
What should patients do if they develop acute weakness?
Yeah, the general guidance, as we talked about, is for acuity is to be evaluated. I think that acuity is like, in most cases, a red flag. Again, the kind of rare exception might be where something has happened repeatedly where we like know the cause. Like if a patient had a short focal motor seizure, and the family is like comfortable because they've seen it before, they know before, and it's stopped and it's getting better, then oftentimes that could be managed at home. But for most cases of acute things, it's better to be evaluated in person.
Great, thank you, Dr. Ray. Given your background in supportive care, what's your recommendation with regards to patients engaging with your group early in the course of their diagnosis?
Yeah, so though we don't have explicit data for early palliative care in neuro-oncology, I think that there has been a lot of research in other cancers where early palliative care has led to improved outcomes. There was an early study by Jennifer Temmel and her group, which looked at stage 4 lung cancer, and that showed improvements in both depression and anxiety scores, but then also surprisingly led to an increase in actual survival. It's a little hard to understand like why that's happened, and that doesn't necessarily translate into looking at early palliative care interventions in other types of cancers. But I think that the important part of the study was showing that early palliative care didn't like increase mortality. So it's not that people go to palliative care and therefore they're encouraged to stop treatment. That is like not the point of palliative care, because the point of palliative care is actually to improve goal concordant care. So care that is in line with those things that are most important to the patient. I think in terms of brain tumors, the thing that I think about often is that because it is affecting the brain, that oftentimes there is some amount of challenges with cognition that may happen gradually over time. And because of that, I think about two reasons for why it's important to have these types of conversations earlier. One is that so that we could have those conversations when you're fully kind of able to engage in those conversations, because later on that might be more difficult if there's some amount of difficulties with cognition. And I find that also for the primary care partner, by having the discussions with them, you also relieve some stress off of them, because then they feel more certain about like what are those things that are important to you. And if an emergency happens, they also know like what would be your preference in cases where those things were not spoken about before. It sometimes can cause more distress for the person who's that care partner in the kind of path or the experience of the brain tumor, right? But I also think that generally speaking, serious illness conversations and discussions with both oncologists, but also with palliative care specialists, have been shown to actually improve goal concordant care. So goal concordant care is what it means is that doing or giving your care or providing and participating in your care that aligns with those things that are most important to you. And so if we could do that even earlier by really being able to talk through your preferences, talk through like what is most important to you, then throughout the course of your treatments, then there could be better and better goal concordance, right? And so for that reason itself, I often think that these are important conversations to have early on. Now, it doesn't necessarily mean that it has to be a palliative care specialist. And I think that these are types of things that it's also good for the patients to bring up with their neuro-oncologists. And one thing that I often find is that like patients sometimes don't want to have those conversations because of the fear of what might be said. But research actually repeatedly shows that patients actually having serious illness conversations improves anxiety about the discussions. And so having the serious illness conversations because it improves the communication, but I think also the relationship with the oncologist actually helps alleviate a lot of the things that are better than left unsaid. And of course, in a conversation like this, we also always go at the pace of the patient, right? And so at times we pause and see like where the patient's at and be able to take them also in like a piecemeal way that is also in their comfort, right? So kind of pushing, pulling a little bit, stretching a little bit, but being able to get to those things that are most important to the patient.
Thank you, Dr. Ray. That's a really helpful overview, and I'm glad you gave people a little bit more of an idea of kind of what kind of conversations and what kind of work you're doing with people in palliative care. For anybody who is on the call who's seen, at Dana-Farber in the Center for Neuro-Oncology or frankly anywhere else, if you have a primary oncologist, it can't hurt if you're interested in knowing more about this. Just talk to your oncologist about it. You may be able to have some of those conversations that Dr. Ree was just mentioning with your oncologist, but there may also be a role for palliative care. So thanks again, Dr. Ree. We're going to move over to some questions now that we received before actually the webinar over email, and then we'll get to audience questions. I had a patient reach out to us who had stage 4 lung cancer, and the brain mets were treated with I'm sorry, I'm going to butcher this, but osimertinib, and they resolved. However, this patient is experiencing persistent neuro-ophthalmologic and cognitive symptoms, and they're wondering, are there any interventions that are helpful for this? And is it possible that these symptoms are a result of, some of the trauma from their cancer treatment, their lung primary cancer treatment? Dr. Lee, I'm going to ask you that question.
So it's probably hard to comment on one individual patient's experience, but sometimes even though the brain tumor was there at one time, and even if you can't see it necessarily now on MRI, there is generally some sort of scar that's left, right? The brain in that area has been disrupted. And even if you can shrink that tumor to the point where you can barely see it, the brain doesn't heal perfectly. So oftentimes people are left with some level of neurologic issue. It could be a cognitive issue. It could be a neurologic deficit. And hearing about the neuro-ophthalmologic issues, I don't know if this is something that was in the vision centers or near the vision center. So that's just one example of like if you had a lesion in the vision center and it damaged the vision center, even just by being there, then sometimes the vision doesn't necessarily go back to normal. There are, in general, interventions that can be tried depending on the symptom to see if we can help things get better. So if there are physical limitations, weakness on one side of the body, there's obviously physical therapy and rehab that can be tried. If you have speech issues, we try speech therapy. For cognitive issues, there is cognitive therapy and other interventions like that. There are some interventions to try. They're not necessarily 100% perfect, but if it can make it better, then maybe worthwhile.
Thanks, Dr. Lee. Yeah, if anybody is wondering more about kind of how to access those resources of cognitive rehabilitation, or even sometimes there are groups, highly recommend the Brigham and Women's has some really great cognitive function groups that are run online virtually, so you don't actually need to go in person. You can do the group from home. So if you are being seen, in our network here at MGB, I highly recommend asking your physician about those. But there are also, like Dr. Lee mentioned, cognitive rehabilitation interventions that are one-on-one, with a provider. So it might, if it's something that might interest you, it is available in this network. We have a few questions from the audience. I'm going to kind of try to go in the order of theme like we did in the webinar so far. So we'll start with the ones related to headaches and migraines. So somebody is wondering, Dr. Rhee, I'm going to ask you this question. If a migraine medication is resolving a headache, does that mean that the headache is not caused by brain metastases?
So not necessarily, only because oftentimes there may be overlaps between like a medication that's used for migraine as well as medication that's used for the pain potentially from the brain meds. So I often think about them in terms of just both like chronicity, the quality of the headaches. So migraines, they're like a more particular definition where oftentimes they might be associated with kind of sensitivity to light, sensitivity to sound, maybe sometimes some nausea. But there's also kind of like a quality of migraines that sometimes can be like more kind of one-sided or painful in terms of like a pounding sensation. But if it is, I would say like maybe the more important thing is like if there is a particular treatment that's being helpful, then I would say that whether it's like from the migraine or the brain met, then we should do that as a treatment. Because especially with symptoms, we're not necessarily thinking about changing like the underlying cause, but rather alleviating that which is affecting your daily lived experience, right? But I guess like to kind of summarize that point, I would say that it's not necessarily the case, but it kind of depends on which medication, and if the migraine medication is not, or migraine interventions are not enough, like not enough to treat what's happening. That's when I often also think about whether it might be tumor related and may need to like step up in terms of the type of intervention that we may need for treatment of the headache.
Thank you, Dr. Rhee. Dr. Lee, someone wants to know, why would my craniotomy scar be painful to lay on or touch a year and a half after a second surgery? It only lasted about a week or two, but hurt a lot.
Yeah, so like Dr. Rhee mentioned, when you cut through the skin, you're also cutting through some nerve endings, right? And so those nerves sometimes heal in a little funky way, and people can sometimes be left with like, strange sensations over the site of where the surgery happened. Some people describe almost like an itchiness feeling. Some people describe like tingling or just a discomfort that's hard to pinpoint. And why does it happen at particular time points after surgery? In some patients and doesn't happen in other patients. I don't think it's 100% clear, but it probably in some respect relates to just how the nerves healed in that area.
Thank you, Dr. Lee. Dr. Rhee, we're going to go back over to you. Any clinical way to diagnose if a person has had a focal seizure after the seizure has occurred?
I guess I'm not like 100% sure what the question means, but I guess if I were to hopefully interpret this correctly, so typically like if it's a focal seizure, because generally speaking, the person hasn't like lost consciousness. Usually, if it's like a focal motor seizure, for example, there might be like the shaking movement that after the seizure is over, oftentimes there's weakness. And so if the seizure like pattern is kind of known, like with a focal motor seizure, where it usually affects that person's like right upper, like right arm, for example. Then sometimes we know because like there is like weakness after. Sometimes I guess patients will also think about this if they may have had a seizure in their sleep and then they woke up and they find that their like right arm is a little bit weaker. I think it's like a little hard to know because sometimes that could be due to seizure, sometimes it could be due to swelling if it wasn't like experienced, like the seizure itself. But those are the things that I would be thinking about if there is a weakness after kind of, I guess, like an unwitnessed type of event, like somebody was sleeping.
Thank you. In some cases, a patient may have to undergo kind of an epileptic workup, right? If they need more information, that would require what usually, let's say, there's no way to diagnose seizures. They want to find out if they're having seizure activity. Maybe we can just talk a little bit about what that process looks like for people.
Yeah, so oftentimes with a seizure workup, a history is very important, and I would say perhaps the most important because oftentimes seizures tend to have what we say a semiology, which we've been talking about this pattern, because usually what's happening is that around the like tumor due to swelling or the tumor itself, there's this coordinated electrical activity. So actually, our brain electrical activity, even though we think it's coordinated, it's actually like uncoordinated. There's electrical activity happening, firing in different ways. And what happens in seizures is that there's like a depolarization or a coordinated electrical activity that happens so that if there's different firing at different times of neurons, then different neurons also recover at different rates. And so you don't have this like weakness or sleepiness or things like that. But if all of the neurons kind of activate at the same time, what happens is that none of them can really activate after because there's like a period of time where the neurons are kind of redistributing their ions to be active again. And so that's kind of what's happening in a seizure. And so because of that, usually there's like a pattern that's similar for each time that like somebody does have a seizure. And so that's why the history is important because if something very stereotyped is happening, then that's when I think about a seizure from the history. Now, that's like not always the case, and there are rare cases where sometimes seizures can just look very different. We often think about this in like maybe this is getting too specific, but in like frontal lobe seizures, so seizures that are happening kind of in the frontal lobe, sometimes they could just be unusual, or even like seizures that are happening maybe deeper can also be unusual. And so in those cases, sometimes we can order things like what's called an EEG, which are kind of electrodes that are placed on the surface of the scalp and can measure this coordinated electrical activity in the brain. And so when we see like a coordinated electrical activity that's kind of has this pattern to it, that's when we think that this is a seizure. And also we try to correlate the electrical activity with a particular symptom. So if somebody like is having the symptom and we see that activity, then we know that likely that's due to a seizure. Of course, like all of these tests are ancillary tests in the sense that like they help us think about the seizure as a diagnosis, but ultimately we want to think about things clinically because just because we don't see it on EEG doesn't mean somebody like might not be having seizures because sometimes you might not just catch it because at EEG you have to like catch it at the time that it's happening, right? So that's one reason. Another reason is that sometimes EEGs, because it can only measure a certain amount of thickness into the skull. If there are still coordinated electrical activity, but happening like deeper or in areas that it's like hard for the electrodes to pick up, it still may be possible that somebody is having a seizure, but not be picked up by the EEG, which is why the clinical picture is really important in terms of like the history and what's happening in terms of the neuro-oncology team also thinking about like whether this may be a seizure or not.
Thank you, Dr. Ray, for elaborating. It's helpful to know all of those details. Dr. Lee, how about scar tissue? Let's say this person is wondering about scar tissue from treatment, so radiation therapy and or surgical resection on seizure activity. Any data there or any clinical experience that you have?
Well, anything that disrupts the electrical activity of the brain, so that could even mean a scar, it could mean an old stroke, it could mean the surgical site, it could mean prior radiation. In theory, any of those things could cause or trigger seizures. But they're less common triggers of seizures than, say, a growing brain tumor, for example, or uh, a very active infection, or I would put scars and in sort of the category of things that are not very active, right? Because that's something that happened in the past and you just have leftover evidence of some old damage, as opposed to active ongoing damage. Those are generally more seizure inducing.
Thank you. That's very helpful information. Let's just stay on you, Dr. Lee, for this next question. Irritability. This person is asking, is irritability a sign of a seizure? I'm going to reframe it. Could it be a sign of a seizure?
So again, maybe I have to interpret what the question is. So there's irritability as in like personality. You're irritable as a person, which I wouldn't necessarily think that irritability per se is a seizure manifestation, although there are some seizures where you just act bizarrely, and so maybe it would manifest in that way. Sometimes some of the seizure medications, like Keppra, can cause mood changes and irritability as a side effect, so sometimes you can see that. And then we also talked about, just in general, that on an EEG, sometimes we see some changes that we say, oh, it looks irritable. It looks like your brain is irritable, right? And prone to seizures. So hopefully I've answered the question.
No, that's interesting. I didn't think of that interpretation that you just brought up, but that also could be it. Not the personality change, but actually the sort of characteristic of the way that the brain is behaving or what have you. Thank you so much. Okay, so we're gonna move back to you, Dr. Ree. How often should symptoms persist, or long should symptoms persist after treatment concludes? And then this person is also wondering if there's anything special about fatigue, if it would be different in any way from other symptoms.
Yeah, so um, I guess it depends on the symptom, because there are certain types of symptoms that are like very treatment related. So, for example, when I think about a very treatment related symptom, I think about like rash, for example, because it's like clearly related to the treatment and also the effect of the treatment as a side effect. But then there are other symptoms where it's hard to disentangle whether the symptom is due to like the treatment or whether it's due to actually the underlying tumor itself. And so I often think about that with like headache, because headache can be due to the tumor itself, but sometimes headaches can also be exacerbated by treatments. And fatigue, I also think of as an example of one of those. Um, as Rachel mentioned in the beginning, I also do research in supportive and palliative care. And part of the research that I do is in symptoms. I'm trying to better understand the symptoms patients experience, and so also try to think about ways to better address and treat symptoms. And one of the things that we're finding is that fatigue especially is very high in the brain tumor population. And when looking at it during a treatment course, but afterwards as well, that it remains high, like both before, after treatment. And so likely that makes me think that because it's also high before treatment, that probably it's related perhaps more to the tumor, but also may have a contribution from the treatment itself. Fatigue is very challenging in terms of similar to headache, where you really want to think through like what are all the reasons why somebody can have fatigue, because fatigue can be due to like many different reasons. And so thinking more about like what is the cause of the fatigue, and therefore to try to address the cause oftentimes may differentiate kind of the causes of fatigue, and therefore think about treatments differently. And so with minor symptoms, the other thing to just reflect on is that treatments themselves also affect other aspects of the body, right? So with chemotherapy, for example, it's not just affecting the cancer cells, but people get blood checkups, et cetera, because of the fact that it can also affect other rapidly dividing cells in the body, which are oftentimes like in the bone marrow, for example. So that's why we do those blood checks. And because of that, oftentimes treatments themselves also may have more lasting effects. And chemotherapy, radiation therapy, really all types of cancer therapies oftentimes may also affect things like fatigue. Whether that be because of the kind of reserve of our body, or whether that be because of certain like neural or nerve networks that are being affected from like radiation, for example, or even just like hormonal imbalances that are happening because of the fact that the treatments may also be affecting that kind of balance in the body as well. And so it can be due to like many different things.
Thank you, Dr. Ray, for that comprehensive answer. Dr. Lee, last question for you. If somebody had brain metastases, would you ever recommend that they have routine eye exams done by an ophthalmologist that's specialized in cancer care so vision changes are properly detected?
Uh, it often depends actually on where the tumors are located. So there are some tumors that can be located near the pathways that control, say, your eye movements or control the coordination of the eyes. And so we often do refer those patients to the neuro-ophthalmologist, who is a specialist, right? To help monitor along with us with those symptoms. But I would say that sort of the routine patient with brain metastases that doesn't have any eye issues, I don't think that you necessarily need to see a specialist. Um, Certainly, if you ever develop any vision issues, it's something definitely to bring up to your doctor. And maybe the doctor can do, a quick bedside exam or make that referral to the eye doctor when appropriate.
Great. Thank you, Dr. Lee, for clarifying. Before we wrap up here, I just wanted to quickly say live to the audience that there was a question in the chat about virtual visits at Dr. Ree's clinic. And he did respond. And just in case somebody is, not reading the chat or can't see it, I just wanted to read his answer out loud. Yes, virtual visits are an option. The only thing is with prescribing medication, the first visit needs to be in person. However, often follow-up visits can be done virtually, and periodically doing an in-person visit is important if medication is being prescribed in any ongoing way, but virtual visits can be had after the first visit. Thank you both, Dr. Lee and Dr. Ree, for a terrific discussion on brain tumor symptoms. I just want to give both of you an opportunity to give any take-home points that you might have to our audience here today.
Well, I would just say that the symptoms from brain tumors often can be managed. So it's good for you to talk to your doctor about your symptoms.
Yeah, and
Great advice.
I would also just say that like symptoms can be distressing because oftentimes they are the things that affect the daily lived experience. And so I would also encourage you that even though in visits, oftentimes, there are a lot of things to talk about, trying to raise the importance of how these things are also affecting you on a very like day-to-day basis. It really impacts the lived experience of somebody who's living with cancer. And so it's very important to also address.
Thank you so much, Dr. Ray and Dr. Lee. Thanks so much, everybody.
I just want to
Thank you.
echo Rachel's gratitude. Thank you all. I just want to mention that this session was recorded and it will be posted on our Blum YouTube playlist. So keep an eye out for that. Thank you both for your time, and I'll launch the poll now.